Evolution of the Fontan procedure 3D medical animation. Over the 40 years since Fontan and Cureus first described their palliative procedure for patients with a single-function ventricle, the operation has undergone several major technical modifications. The Fontan operation was first performed by Fontan and Baudet in 1971 and heralded a new era in the management of patients with a functionally univentricular heart. Despite many minor modifications, the Fontan-Cureus operation can generally be classified as falling into three, and perhaps now, with the introduction of the intra-extracardiac conduit, 4 generational periods. Chosat et al. 1977 delineated selection criteria to define an ideal candidate for a Fontan procedure. Alain Chosat, 1937 to 2003. They described the 10 following criteria, which are occasionally and facetiously referred to as the 10 commandments for an ideal Fontan operation result. Table 1. Selection criteria for the Fontan operation. Original 10 commandments. Minimum age, 4 years. Sinus rhythm. Normal caval drainage. Right atrium of normal volume. Mean pulmonary artery pressure less than 15 mmHg. Pulmonary alveolar resistance less than 4 UM2. Pulmonary artery to aorta diameter ratio greater than 0.75. Normal ventricular function, ejection fraction greater than 0.6. Competent left atrioventricular valve. No impairing effects of previous shunts. Revised criteria. Minimum age less than 4 years. Lowest and optimal age for performing Fontan operation unknown. Sinus rhythm desired. Normal caval drainage desired. Small size atrium contraindication for lateral tunnel Fontan. Mean pulmonary artery pressure less than 15 mmHg. Pulmonary alveolar resistance less than 4 UM2. Adequate size of pulmonary vascular bed. Use of McCune and Nakata index may be helpful. Preserve ventricular systolic and diastolic function. Competent atrioventricular valve. No impairing effects of previous shunts. Patients who do fulfill some, but not all, criteria are regarded as medium to high-risk Fontan candidates. Surgical procedures such as left atrioventricular valve repair or pulmonary artery repair can improve Fontan suitability. The selection criteria are less tight for performing an initial cavopulmonary shunt. The first generation atriopulmonary Fontan-Cureus procedure. Fontan's original description of the right heart bypass involved a Fontan and Baudet, 1971. 1. Classic Glenn shunt consisted of an end-to-end anastomosis of the right pulmonary artery, RPA, to the superior vena cava, SVC. 2. Connection to the right atrium to the left pulmonary artery using a homograph conduit. 3. A second homograph valve was placed at the atriocaval junction. 4. Closure of the atrial septal defect, ASD. 5. Ligation of the main pulmonary artery, PA. At that time, RA contractions were thought to be important in pulsatile assistance to the pulmonary circulation. Classic Glenn shunt. Insertion of an aortic homograph between RA and RPA. Insertion of another allograft valve in the IVC-RA junction. Closure of the ASD. Modification by Cureus et al. 1973. 1. Anastomosis of the right atrial appendage, RAA, and the main pulmonary artery, with its intact pulmonary valve. 2. Closure of the atrial septal defect, ASD, and the ventricular septal defect, VSD. 3. No Glenn operation. 4. No IVC valve used. Atriopulmonary anastomosis placement was done between the superior vena cava, SVC, and the aorta at the roof of the right atrium. Modification by Bjork et al. 1979. 1.
direct anastomosis between the right atrial appendage, RAA, and right ventricular outflow tract in patients with a normal pulmonary valve, using a roof of pericardium to avoid a synthetic tube graft. Modification: direct anastomosis of RA to RPA.
Second generation lateral tunnel Fontan (LTF) procedure. The lateral tunnel procedure for patients with mitral atresia was first described by Puga et al. From the Mayo Clinic. They recognized that patients with an anomaly such as double outlet right ventricle with mitral atresia presented particular challenges when trying to apply the first generation atriopulmonary Fontan operative technique of single-stage lateral tunnel Fontan (LTF) with Gore-Tex intra-atrial baffle.
1. The procedure is performed via median sternotomy on cardiopulmonary bypass with moderate hypothermia, e.g. 28 to 30 degrees Celsius. 2. An end-to-side anastomosis is then performed between the SVC and right pulmonary artery using a running 6x0 or 7x0 polypropylene bidirectional Glenn shunt. 3. The main pulmonary artery is transected with closure of both the proximal and distal stumps. 4. The right atrium is opened parallel to the crest of the septum. 5. The length of the baffle is measured between the Eustachian valve and crista terminalis. 6. The intra-atrial pathway is a composite tunnel made of the atrial sinus venarum and a Gore-Tex patch which measures 16 mm in diameter, is cut to length, split longitudinally, and shaped incorporating a 4 to 5 mm fenestration. 7. The prosthetic baffle is sewn in around the upper half of the junction of the IVC with the right atrium along with the posterior wall of the atrial septum, taking care not to injure the sinus node and the crista terminalis, the prominent ridge in front of the SVC, and finally, the anterior wall of the atrium. 8. The coronary sinus remains outside the baffle. 9. The atrial incision is closed with a running 5x0 polypropylene suture. 10. The undersurface of the right pulmonary artery is incised so that an unobstructed anastomosis can be created between the intra-atrial tunnel and the pulmonary artery. 11. The SVC stump is then anastomosed to the undersurface of the right pulmonary artery by 5x0 polypropylene sutures. 12. It may be necessary to enlarge the anastomosis with a patchplasty, but care had to be taken not to compromise the sinus node or its artery. The Hemifontan HF operation. The Hemifontan HF operation is a staging procedure in the journey towards an ultimate Fontan palliation. Although popular in the Western world, it has found limited application in the developing world. Norwood and Jacobs first described the HF procedure in 1989. It is a staging procedure devised for single ventricle patients in whom primary Fontan operation is not advisable. Since only part of the systemic venous return is directed to the pulmonary circulation and the ventricle is only partially offloaded, these children are expected to undergo Fontan completion in the future. A HF operation differs from a bidirectional Glenn operation, BDG, in many aspects. A BDG involves extensive circumferential mobilization and transection of the superior vena cava, SVC, to create an end-to-side anastomosis between the SVC and RPA. Since a HF procedure preserved the natural SVC to RA confluence, it provided a more physiological flow of blood to the pulmonary circulation. The essential components of a HF procedure include A. Anastomosis between the SVC to RA confluence and the central and branch PAs to direct the SVC blood to the pulmonary circulation. B. Homograph patch augmentation of the central and branch PAs. C. Interruption of the SVC blood from reaching RA using the homograph dam. D.
interruption of the antegrade pulmonary blood flow by transecting the main PA and closing its cardiac end and ligating all other sources of pulmonary blood flow. And E. Additional procedures as atrial septectomy, repair of total anomalous pulmonary venous connection, aortic valve repair, etc., in preparation for future Fontan operation. Operative technique. The HF procedure directs the SVC blood to pulmonary circulation. 1. The surgery is performed through a median sternotomy incision. 2. Cardiopulmonary bypass (CPB) is established with aortic and right atrial cannulation. 3. The patient is cooled to profound hypothermia and all the extra sources of pulmonary blood flow are ligated. 4. Dissection is carried out to free the SVC, central and branch PAs, and the RA. 5. After cross-clamping the aorta, cold blood cardioplegia is delivered through the aortic root and circulation is stopped temporarily. 6. For the performance of a HF, the right atrial cannula is removed and the RA is opened in its superiormost portions with the incision extending onto the SVC. 7. The incision in the PA is placed in the central PA and extended to both branches up to the takeoff of the upper lobe branch. 8. At this point, the antegrade pulmonary blood flow is interrupted by transecting the main PA and oversawing the cardiac end. 9. The SVC-RA junction is anastomosed to the right and central PA in a side-to-side fashion. 10. An appropriately sized cryopreserved pulmonary homograph is used to augment the branch PA as well as to create a dam occluding the flow of blood from the SVC to the RA, after enlarging the size of the SVC-RA junction to the size of the IVC orifice. 11. The anastomosis is completed, the heart is de-aired, venous cannula is reinserted, and CBP is resumed. 12. Patient is rewarmed, aortic cross-clamp is released, and the rest of the operation is completed in the usual manner. Third generation, the extracardiac conduit Fontan procedure, ECC. In 1990, Marcelletti et al. Published an influential paper in the Journal of Thoracic and Cardiovascular Surgery entitled Inferior Vena Cava, Cava Pulmonary Artery Extracardiac Conduit. The rationale for this procedure was that it eliminated exposure of any atrial wall to the elevated venous pressure of the Fontan circuit. The ECC includes direct connection of the superior vena cava, or cave, to the pulmonary arteries, and placement of a tube graft outside the heart from the inferior vena cava to the pulmonary arteries. Operative technique. ECC is typically performed following a previous superior cava pulmonary anastomosis. 1. Exposure is via a repeat median sternotomy. 2. Dissection included enough of the ascending aorta and superior vena cava to cannulate the two divisions of the right pulmonary artery, the central and left pulmonary artery behind the aorta, the right atrium, and the inferior vena cava. 3. The inferior vena cava is dissected into its diaphragmatic hiatus until the hepatic veins are visualized. 4. Following heparinization, the aorta is cannulated, and the right-angled cannulae, DLP, Medtronic, Minneapolis, MN, are placed in the vena cava. 5. Although not always used, a sump placed in the atrium can be useful to drain pulmonary venous return, which can be copious, depending on the extent of the artopulmonary collaterals. 6. The patient's temperature is maintained above 32 degrees Celsius, and the heart is maintained beating throughout the procedure. 7. Divide the IVC after clamping the atrial-IVC junction more towards the atrial tissue. 8. A Gore-Tex 2 graft, as per the size recommended for the patient, is used and sewn end-to-end to the transected IVC. 9. An incision is made on the inferior aspect of the pulmonary arteries,
extending from the lower division on the right toward the left pulmonary artery. This incision generally lies opposite to the superior cavo-pulmonary anastomosis. 10. The length of the conduit is carefully assessed from the inferior cavo-anastomosis to the lower division of the right pulmonary artery. 11. The conduit is cut on a slight bevel and sewn to the opening in the pulmonary arteries. 12. The conduit should lie in a slight curve without distortion of the right pulmonary artery or compression of the right upper pulmonary vein, which lies immediately posterior. 13. A fenestration can be placed as a routine or selectively once hemodynamics are assessed after weaning from cardiopulmonary bypass. Fourth generation, the Intra-extracardiac Fontan, IECF. Since the Intra-extracardiac Fontan, IECF, was popularized by Jonas in 2008, its claimed advantages over traditional extracardiac or lateral tunnel Fontan are simplicity, suitability for nearly all subsets, flow characteristics, low risk of sinus node artery injury, and possibly a lower incidence of arrhythmias. In a head-to-head comparison between the IECF and the LTF, the IECF has been shown to combine the benefits of the LTF and the ECF. It has been claimed to improve clinical outcomes, reduce injury to the sinus node artery, and crista terminalis is easy to fenestrate and also claimed to produce minimal disruption of atrial conduction pathways. Operative technique. 1. The IECF was performed with aortobicaval cannulation on standard moderately hypothermic 28 degrees Celsius CPB. 2. After the aorta was cross-clamped, the heart was arrested by a single dose of del nido cardioplegia. 3. A transverse incision was made in the lower RA, taking care to avoid the crista terminalis, and an appropriately sized conduit was sewn to the IVC at its opening into the RA. 4. A 4 mm aortic punch was used to fenestrate the conduit near its IVC end for a case of cannulating it by a catheter, should an antiarrhythmia procedure be needed later. 5. A fenestration was performed for all patients undergoing IECF, unlike the ECF. 6. The other end of the graft was taken out from the RA. 7. The graft was sutured to the atrial wall at the point of its exit from the RA, while the RA closure was performed with the graft in situ in 2 layers. 8. An inverted T-shaped incision was then made in the right PA, and the incision was extended into the superior vena cava, SVC. 9. The upper end of the graft was then sutured to this opening. 10. The CBP is then terminated in the usual fashion. Concept of fenestration in Fontan circulation. In 1990, the same year when the extracardiac Fontan was proposed, Dr. Nancy D. Bridges and Dr. Aldo Castaneda from Boston introduced the concept of fenestration, which was initially performed in high-risk patients. It was supposed to reduce the systemic venous congestion and provide preload to the single ventricle to maintain cardiac output at the cost of some desaturation. It was soon noted that high-risk patients recovered rapidly with lower incidence of persistent pleural effusions. They proposed the following criteria to consider Fontan a high risk. A. Mean pulmonary artery pressure greater than 18 mmHg. B. Atrioventricular valve regurgitation. C. Pulmonary artery distortion. D. Pulmonary vascular resistance greater than 2 Woods units. E. Systemic outflow obstruction. F. Complex anatomy. A. The IVC is transected at the cavo-atrial junction and the right atrial is sutured all around to punch on the extracardiac conduit. B. The atrial end is patch closed and a hole in the patch is sutured to the fenestration created on the extracardiac conduit. C. The divided atrial end is partially closed and the open end of the atrium is sutured around a fenestration created on the conduit. D. The vena cava and the pulmonary artery end of the conduit is sutured, and the atrium which lies close to the conduit is sutured onto a fenestration created on the conduit as onlay fashion.
Melbourne technique of fenestration.
A. The fenestration is made on the lower left aspect of the graft, just in front of the atrial orifice of the inferior vena cava. B. The orifice of the inferior vena cava is sutured to the conduit, making sure the suture bites stay away from the edge of the fenestration. E. Interposition graft. A graft diameter 4 to 5 mm can be sutured between the conduit and the atrial wall, the advantage being the ease of closure of the communication and titrating the size of the communication depending on the hemodynamics. F. Creation of fenestration and its durability is possibly the best in lateral tunnel Fontan, or intra-extracardiac conduit, where in the baffle or the portion of conduit which is intra-atrial is fenestrated to drain into the atrium. G. A fenestration can be placed as a routine or selectively once hemodynamics are assessed after weaning from cardiopulmonary bypass. One effective technique is illustrated. A hole is placed in the side of the conduit using a punch. The size of the hole is generally 4 mm if the patient weighs less than 15 kilograms and 5 mm if greater than 15 kilograms. A side-biting clamp is placed on the lateral wall of the right atrium, staying anterior and inferior to the location of the sinoatrial node. The electrocardiogram is observed to ensure maintenance of P waves. The incision is made in the atrium and sewn side to side to the conduit, taking partial thickness bites of the Gore-Tex away from the edge of the punch hole. Closing snare is left around the fenestration.
One method of fenestration involves a purse string around the fenestration, which is kept in the subcutaneous tissue for under local anesthesia, without the need for reduced sternotomy, described by Hyla Lax.